Once again, thank you for attending, and it's really my privilege to be able to talk to you a little bit about cancer and really how we treat cancer has been changing over the past few years. Really, what the paradigm shifts in cancer management have been based on a better understanding of the science behind tumor biology. Now, I'm assuming not all of you have a science background, and that's okay. And forgive me if I dumb things down a little bit if you do. I'll try to explain things in a more general way, but please feel free to ask any questions, or if you would like me to go through anything or explain it a little bit more. What I'd like to do is kind of go through from both a scientific as well as a historical context of how we manage cancer and how it's changed over the years. And, you know, cancer is important to me. I mean, I'm a cancer surgeon in a way, and it's something that I'm interested in doing. I also had a PhD in molecular biology. And, you know, it's something besides the science behind it, it's actually very important to me. And I think many of you know somebody who may have cancer or may have had cancer yourself. I think cancer is one of these things that really influences everybody's lives in some way. And it's something that we are only coming to grips with, really what it is and what it means. So the objectives of this talk is to really dive into what is cancer and ask some challenging questions in terms of why is cancer so hard to treat, and what are some ways we're learning to overcome the complexity of tumors. And in terms of the first question, what is cancer? You know, we can look at cancer in terms of the biology of really changes in a cell. And really, what we're learning is that things are quite complicated, that there are, we can look at it in terms of almost like a circuit or a system of inputs and outputs and traffic lights and roads. And it's really something that we really are coming to grips with, because there have been times we've looked at it from a distance, and there have been times that we've come in too close and looked at it too close and lost the big picture of really what's going on. There's some definitions that cancer is a disorganized cell or tissue which develops a capability to invade and spread, and therefore has some sort of life-threatening possibility. If we look at it from a philosophical context, cancer is the ultimate act of betrayal, because it really is yourself acting against yourself in a way that is very profound and hard to grip. And in general, the answer is complicated. So this is a figure from a pretty important publication that back in 2001, a scientist named Hanahan summarized basically about 8 important findings that he suggested were important, what he called hallmarks of cancer. And really, this hasn't changed much in the last decade. It was published again after 10 years, and they basically total about 10 hallmarks of cancer. And we'll go into some of them, but these are some of these different places where we, as both scientists and clinicians, are trying to find ways to more or less target cancer, more specifically, rather than how we had been in the past, just hitting cancer on the head with a hammer. So one of these elements is something called disordered growth. Some of the terms that are sometimes used is a word called proliferation. And it's just the ability of a cell or tissue to grow beyond its domain, or how it should be normally growing. And if you think of your colon cells actually turn over once every 3 days. So you actually don't really keep your colon cells very long. And what we'll discuss here is that there are times where you can get disordered growth, meaning that the cells just keep on replicating or dividing in an uncontrolled fashion. And this may be one of the first early steps in development of a tumor. And what we see here on the left, basically that's a polyp. That's a benign growth in a way, but it's known to that these types of polyps, that if you give it enough time, give it 10 years down the road, it may turn into what we saw on the right, a colon cancer that has the capability not only to invade, but perhaps to spread to both lymph nodes, as well as perhaps to spread to other organs. So growth isn't the only element of being a cancer, but it was one of the early elements that we see. And there was a pediatrician and scientist named Bert Vogelstein who in the 1990s came up with this hypothesis. Hypothesis is basically when you present something scientifically, you claim something, and then you present evidence to defend a claim. But presented something which he called the adenoma to carcinoma sequence, which he presented as that there are several events that happen in the lifespan of a polyp that slowly turn it into a cancer. And there are some, and he was a pediatrician, and he was noting that even, there are some people who have family history of polyps who at very young ages, in their teens, develop hundreds of polyps scattering their colon. And they discovered a mutation that was one of the early events in colon cancer formation, and they call this the APC gene, which is the adenomatous polyposis coli gene. And it's one of the early events in this where you start with getting all these polyps, and then you give it enough time, and a couple more mutations happen along the way, and then you can develop what's considered an invasive cancer. And this same kind of a spectrum of going from something that almost seems like something benign to a cancer is actually now proposed in esophageal cancer as well as even breast cancer. One of the other elements is the whole concept of a cell or tissue finding a way to evade its own death. And I mentioned that for the colon, that your colon normally turns over every 3 days. Those colon cells have to go somewhere. And basically there is a process where your cells are able to more or less die on their own and not consume all the energy that basically the energy then is kept by the body. And they call this apoptosis. And it's basically a controlled death. You want it to happen, actually. And cancer cells, for some reason, have ways to evade this, and they're able to become sort of immortal, that they keep on replicating and keep on going and keep on dividing, and they find ways to avoid these pathways that lead to their own death. Another thing that some cancer cells have learned to do is they learn to evade the immune system. And basically everybody with an intact immune system is typically able to then kind of patrol for abnormal cells. One of the hard parts of cancer cells is they often look very like your own because they're derived from your own cells. So they somewhat are, in their own way, able to evade it, immune-related policeman activity. But at the same time, tumors have a extraordinary capability of hiding themselves from the immune system. The other thing that tumors learn to do is something called angiogenesis, or the ability to recruit their own blood vessels. And really, if you are trying to even grow a tumor outside of the body in just taking cells in culture, you're limited in terms of your ability to grow based on concepts of diffusion or the ability of nutrients to pass as well as oxygen gradients. And really, you're not capable of growing a cell much greater than a cubic centimeter, basically because of the limitations without having their own blood supply. And tumors have a way of recruiting their own blood supply at some point which allow them to progress. One of the things that's interesting about tumors' blood supply, and we'll kind of briefly go over it, is it's not quite normal. There are some abnormalities of tumor blood supplies that are quite different from your regular tissue blood supply, and that in and of itself may make it we take advantage in a way of in our ability to image tumors with certain types of studies like MRIs, because they actually wash out contrast differently because their blood supply is leakier than normal tissue. One of the other steps that tumors develop is the ability for these cells that normally just sit there in their proposed spot, depending on what kind of tissue they're derived from. They gain motility, and they gain the ability to invade beyond where they should be. Okay, and once they basically are able to invade or gain this capability of moving from where they should be to another place, that's when we call it an invasive cancer. Basically, what ends up happening is after it gains the capability of invasion, then tumors can gain the capability of not just leaving their place of origin, but to spread to distant sites. And they can actually spread via lymphatic channels to lymph nodes, which is common for certain kinds of tumors. And other kinds of tumors can spread via blood vessels to various sites in the body. And this whole process we call metastasis. And it actually, in and of itself, we don't understand. But metastasis is really the problem in terms of dealing with most cancers. If they just stayed where they were, we would be able to handle them most of the time, whether by surgical means or other means. It's really dealing with tumors that have gained the capability to spread to other organs. That's really one of the hardest parts to treat. Oftentimes, we, depending on the tissue of origin, we will basically stage a cancer, and that basically, in most contexts, we stage from stage 1, which is typically a very local tumor in its original tissue of origin. And stage 3 might be a situation where it's spread to lymph nodes, and stage 4 may be where it's spread to other sites. And typically most death related to cancer is from stage 4 cancer. Okay, it's not common in the earlier type of cancer. The other thing that's interesting is that every type of tissue, every type of cancer in and of itself may have its own predilection for where it wants to go. And in this context, every cancer is different. But what we've learned about comparing breast cancers from colon cancers to other kinds of cancers is the ones that do spread typically basically spread to certain organs and not to others, or have preferences to spreading to certain organs. And a scientist named Fiedler called this the seed soil hypothesis, where basically that it really was a interaction between the tumor itself and where the tumor was going to deposit itself, or the soil, that actually allowed for metastasis. And we're still kind of learning in terms of what are ways to prevent metastasis and acting on those influences of the seed soil phenomenon may be one way to prevent a tumor cell from spreading. And the reality is, even in patients who don't have obvious metastasis, it's possible to, for example, a mouse, to inject a mouse with a million cells of a tumor and find that only 1 or 2 of those cells actually become a metastasis. So it's actually not a very efficient process, this whole phenomenon of metastasis. And it is possible, actually, for metastasis to happen, but you just don't know about it, and these cells can remain dormant and then present themselves even 20 years down the line, and you just don't know it. So this has been, metastasis to the scientific community is one of the most confusing things, and we're still learning a lot about it. But to answer our question, what is cancer? So we kind of named off a lot of different things that cancers do, but really, what is it? And it still depends. It depends on the cell type or tissue of origin, what it does, and how it presents, and how it manifests itself. And each cancer may be different in the sense that they may depend on specific mutations. And even if we talk about one breast cancer to another, we're seeing patterns where there may be actually 5 types of breast cancer, but even one individual's breast cancer may not be the same as another individual's, even if you can categorize them. And it may be specific to that person's both their genetics as well as the tumor biology itself. And we can say for sure that there are hundreds of types of cancers, but how we categorize them best is basically by their tissue of origin. And what I have here on this picture is a chart that summarizes the top 10 cancers of each gender in terms of incidence, meaning the number of new cases per year. And this is just US data. The data is quite different in other countries if we look at the world. But for men in the United States, the most common cancer is actually prostate cancer, followed by lung cancer and colon cancer in the top 3. For women, the number 1 cancer is breast cancer, followed by lung cancer, and then colorectal. If you combine both men and women, lung cancer ends up being the number 1 in terms of most prevalent amongst humans in the United States. But if you're just going solely by gender, it's breast and prostate. Now, looking at mortality, so this is not how many people present with cancer per year, but how many people actually die per year of these cancers. And on both sides, lung cancer is the most common cause of death. Breast and prostate are actually number 2, and colon cancer is number 3. And over the past few years, pancreas cancer, which is one of the harder to treat cancers out there, has kind of crept up to number 4. It is less prevalent. There are less people with pancreas cancer, but because it's harder to treat, more people actually die from it. So we often go into what causes cancer, whether it's your genetics, what you've been born with, or your environment. And it really is a bit of both. And you have to remember that your environment, it's in and of itself, can influence genetics to a certain degree because it may influence expression of certain proteins or what we're learning more in terms of how DNA is folded or kept aside, that certain elements of environment changes what genes are more prevalent or more predominantly basically expressed. And then environment, we classically think of things like smoking exposure, but other elements have been studied. I mean, we do know for melanoma, UV sun exposure and tanning beds are important features that may influence the presentation of melanoma, especially in certain patients who do have genetics as well that also predisposes to that. So it's a combination of things. I think one of the important things to remember is that when we talk about hereditary cancer syndromes, really only 10 to 15% of cancers that we see are actually due to a strong family history or a known hereditary mutation. There may be other cancers that are just related to your family history but not related to a known mutation. So now I'm just going to talk about types of genes and types of mutations. Okay, and mutation you can think of is basically an event that alters your DNA to some degree. And in the 1970s, really there was a lot of interest in this new term coined oncogenes, or cancer-related genes, when scientists started studying mouse tumors that were mutated with viruses. And basically they then thought that all tumors were somehow related to viral causes, which now, as we've learned, is not the case. But there are several viruses that can cause mutations in certain genes that can allow them to act up. And when you hear of something that's termed an oncogene, it's basically a mutation that causes, almost like putting your foot on an the accelerator pedal in your car, it causes that car to speed up. Okay, it causes those growth and proliferation signals we were talking about that causes the cell to divide more rapidly and to act like a cancer. So here is what is called a proto-oncogene, or just a gene before it's mutated. And when it gets a mutation, it only needs one mutation in it to kind of turn on this irregular behavior that causes the cell to speed up. This is different from another class of genes we've learned about since more or less the 1980s. And that gene that I mentioned that Bert Vogelstein discovered, the APC gene that causes polyps in colons in patients with a family history of colon polyps, that's a tumor suppressor gene. And that's a kind of gene where you actually need both copies. You get one chromosome from your mother, one from your father. You need basically both copies to be mutated to lead to cancer. So they are actually, as the word says, they're there to suppress a tumor or suppress basically tumor formation. And this was kind of at one point called Knudsen's two-hit hypothesis, that certain genes required two mutations to turn towards cancer. And basically what you have to do is cause a mutation to, if you think of it as the brakes in your car, you have to basically take out both brakes to be able to prevent your car from stopping. And that way you continue accelerating if you have an oncogenic mutation and you can't stop the car or prevent it from speeding up, and therefore it even goes faster. So this is a cartoon illustrating this, and this is basically two tumor suppressor genes. And there's some people who are considered carriers where they might already have one of them mutated at birth, and that's why they only need to have one mutation in their life, and they will get not necessarily get a cancer, but be more predisposed to cancer. So in this situation, their second gene is mutated, and they no longer have brakes on their car. And so if you then have another problem where your car accelerates, you just can't slow it down. There's a third class of genes, and that's the DNA repair genes. And these are basically genes that serve to assist with repair of damage to our DNA. And they're basically housekeeping genes. And one amidst this class is basically the BRCA1 and BRCA2 genes. And you may have heard of Angelina Jolie. Earlier last year, she basically wrote a New York Times article that described how she found that she was BRCA positive, and she, because of that, chose to have bilateral prophylactic mastectomies and bilateral prophylactic salpingo-oophorectomies, meaning removal of her ovaries. And basically, that's a choice because we now know that patients who have certain BRCA mutations have an increased risk, and it's a variable increased risk. It's anywhere from 40 to 60% increased risk in ovarian cancer, and somewhere in 60 to 80% risk of developing breast cancer. Now, you have to take it into context that every woman in this country has some risk of developing breast cancer, and that's just because they're women. And that's also because they're living long enough to avoid getting death from other causes that we used to die from, including infectious diseases and cardiac diseases. And the risk for women in this country is now 1 in 9 or 12%, okay? Having a 12% risk of breast cancer doesn't mean everybody gets bilateral prophylactic mastectomy. But for a patient who knows that they have a risk of 60 to 80%, that's not an unreasonable decision. And more so, the choice of doing an oophorectomy, which really, unlike breast cancer, there is no good way of surveilling or preventing. In that sense, I think it's actually a more important decision, but it's also a tricky decision because if you're still in your childbearing years, you may have to calculate that risk into your choices. So basically, with this new knowledge of information, of the ability to test your own genome, we've now come to a point where we actually have to teach people how to deal with that knowledge. And this is not always done by physicians. We have actually, in the clinical setting, a process where we use genetic counselors who are specially trained in the discussion of not just the risks involved, but the in terms of taking into account probabilities and discussing what that really means to an individual person, and taking out also in the context of their individual family history. This whole BRCA gene has been of interest because it also had come to the Supreme Court. There was a company called Myriad, which until recently was the only company that could do testing on the BRCA gene, and that's because they filed a patent on the gene itself. And the whole question came upon, can you patent something natural like a gene? And now, since last year, we can patent processes related to the testing of genetics, but you cannot specifically patent the gene itself. So you can patent what's called cDNA and some of the elements about testing. But it's been a big deal because to get this test, it's something that out of pocket may cost you $3,000 to $4,000 to get it. If you do not have breast cancer, if you're doing it for discussion of prophylactic surgery, it's something that you may have to pay out of pocket without having it covered by your insurance. So it's a big deal, and by having the patent eliminated, now other companies can compete with Myriad and decrease the cost potentially of the whole process, although we will see if that happens much. So going on to the question of can we eradicate cancer, think it's important to look at really the trends we've seen over the last, this is more or less last 80 years. And you've seen basically that the biggest hump on this, which peaked around 1990 and has gone down. And the top row of colors is men by site, and the bottom row is women. So for both men and women, this red line is actually lung cancer. And you can see that it really, since the 1950s, had gone up and then has come down somewhat, but not completely eliminated. What's interesting is this yellow line, which used to be in the 1930s a very common cause of cancer, and that's stomach cancer. And we don't often think about stomach cancer as a big deal, but there was a time when it was actually seen to be quite prevalent and basically the leading cause of cancer death in the earlier part of the last century. And other things of note is, besides lung cancer, are these gradual drops in the blue line, which is colon cancer, as well as the pink line, which is breast cancer. And really, in terms of explaining all this, really the most important thing that we can account for these decreases in cancer deaths is prevention, and partly early detection, but mostly prevention. And you can say that the gastric cancer has decreased partly because of public health measures related to sanitation and refrigeration, and the less use of nitrates and preservatives in terms of meats and other products that we commonly eat. We in general eat fresher food than we used to 100 years ago. Or process it or keep it differently than we used to. In terms of smoking cessation, it may be one of the elements in terms of decreasing the mortality from lung cancer over the last 2 decades, although I think in this country it's still prevalent in terms of 20% to 25% of people still smoke, so it still is a big deal. And you can see that for women it sort of has kind of more or less plateaued, or at least lagged in its decline. The whole issue of breast cancer mortality decreasing is something that has been debated well, and there has been a lot of questioning whether there really has been notable benefits from the wider spread use of mammography as a screening tool. And one of the things is that we have seen from screening mammography is that you do have an increased detection of earlier cancers. And there's been some debate in terms of whether we actually are seeing too many of these earlier cancers now, and we're leading to a process of overdiagnosis of cancers that aren't necessarily going to really affect a person or kill a person. But we can see from at least from these graphs that mortality, which I think is something we do care about, has declined over the last 2 decades. The same thing is the role of colonoscopy. I think there is quite a bit more data that we're seeing a lot more early stage cancers, or just taking care of polyps for the most part, because a good proportion of the population does participate in screening colonoscopy, which is typically done after year 50. And that's typically done on a 10-year basis, partly because what we talked about before, it takes about that much time for an adenoma or a polyp to become a cancer in the colon setting. So we often use terms like war when we talk about cancer. And the war on cancer in and of itself was coined in the early 1970s when Richard Nixon actually appropriated $100 million to be spent in the eradication of cancer, and basically provided a lot of funding for the National Cancer Institute. And, you know, a lot of this money has been quite important in terms of our ability to do research, although there are some questions and debate in terms of how well are we appropriating that money, as well as the costs of certain types of specific cancer therapies if they're being put into a place where they can be used that are actually of value and impact. Like we talked about, that screening may actually have more of a role in terms of catching cancers before they become cancers than trying to fight patients who have cancers that have already spread to other organs or metastatic disease. It may be of more value from a cost effectiveness standpoint, but that's still to be debated. In terms of cancer therapies that we talk about, we can divide them in a couple categories. And one is the local or the regional therapies. And those are therapies which you act on really the tissue of origin of the tumor. That it's in surgery, you cut it out. And occasionally you cut out the lymph nodes as well that are associated with that tumor location. Radiation therapy is another local regional therapy because you can kind of focus the radiation field to a certain location and basically treat one area and preserve the integrity of the areas that you shield from the radiation. There are also some therapies that I put in quotes as empiric therapies. And this is opposed to targeted therapies. And when I use the word empiric, it basically is a concept where you are basically treating something without knowing exactly what you're treating or how you're treating it, but you're giving a medication with the hopes that that medication is going to help. And hope that that medication is not going to have toxic effects at the same time. And for example, if I came in and I noticed I had an abscess on my leg, I might decide to do surgery and open it up. But I also may actually put myself on antibiotics because my leg is red and looks infected. And I feel like I need to treat just in case. But I'll also get a culture to make sure that what the bacteria is. So empirically is when you treat something with an antibiotic that you're hoping that will cover it. So you try something broad spectrum and try to hit a lot of targets potentially. But a targeted therapy is something where after you know really what you're treating, then you go after that specifically. And what we've seen in recent eras is the greater use of focused or targeted therapies. And really one of the first targeted therapy on the right is a picture of Charles Huggins, who won the 1966 Nobel Prize for discovering the use of endocrine therapy for prostate cancer. And he learned that prostate cancer may be hormonally sensitive in certain instances. And we now use hormonal therapies all the time in certain types of breast cancer because we now can test the breast cancer, the tumor itself, and see if it expresses the estrogen and the progesterone receptor. And if it does, then we can put the patient actually on an inhibitor of those receptors, typically for 5 years, a pill, and treat them with this really usually well-tolerated pill as a cancer therapy, in addition to possible cytotoxic chemotherapy, but sometimes without it. There are also other therapies that we've developed over the last decade or two that are antibodies. And antibodies are normal parts of your immune system. that are proteins that are very specific for another protein. And what you can do is actually create antibodies, whether it be in mice or rabbits, and create them to actually resemble human antibodies. And they now have more complicated ways of doing this, that they don't even need to involve animals anymore. But you can create these antibodies and then use them intravenously as a treatment against a certain cancer if it expresses that protein. And then furthermore, because of new advances in drug therapy, we can actually create blockers that kind of fit into an element of a protein that can kind of disrupt that protein and prevent it from doing whatever bad thing it was doing, whether it be forcing the cell to continually divide. And they call those small molecule inhibitors or small molecule blockers. So just to kind of go through one paradigm, one of the most common treated cancers in this country is actually breast cancer in women. And if you can imagine, before the 1860s, when anesthesia was kind of introduced into the use of surgery, there was actually somewhat of a practice of mastectomy on occasion, and even in the Smith Papyrus, there's descriptions of people who had, whether it be heat treatment for breast tumors or who had surgical management of breast cancers. But really, surgery in and of itself is a infant. It's still in its development, because really anesthesia is what allowed surgery to become something that is practiced today. In addition, the turn of the 1900s was a time when the whole practice of antisepsis also came into practice, making surgery a lot safer in and of itself. And over here is a picture of William Stewart Halstead, who was the one, basically when Johns Hopkins was a newly formed hospital during that the turn of the century. He became the first chairman of surgery, and he developed and introduced the German system of the residency program to the United States. He also invented the concept of local anesthesia, and he became first a cocaine addict and then a morphine addict, trying to get over his cocaine addiction, because he did some of the first experiments on himself. Unfortunately, that more or less tortured his life to a certain extent in getting over it. But at that time, he did experimenting both in ways to solve the problem of abdominal wall hernias, but also in treating breast cancer. And he published some of the first good reports of people living long periods of time with after surgical management of breast cancer. The one thing is he did more or less a very, what we call radical a procedure, radical mastectomy. Basically a procedure that not only removed the breast, but removed the pectoralis muscle that is below it, as well as all the lymph nodes in that nodal basin. And this was all predicated on a notion that breast cancer spreads locally, and then it spreads regionally via lymphatics. And I think one of the things to just note is this also predates a time when patients presented with very advanced tumors. There was no process of screening of any way, of course. People who presented with breast cancer more often than not had large fungating tumors. So it perhaps may have been appropriate therapy at that time for what they were dealing with. But this whole notion of big surgery kind of continued in this country, and really it was challenged more in Europe, where in the 1950s, lumpectomy, or just removing the breast tumor itself and then addressing the axillary nodes, was performed more in European settings with good results, and it remained more or less unchallenged, unfortunately, in this country. And then what ended up happening is a paradigm shift in how we looked at cancer in this country, and that came from an argument that was purely scientific. And this is Bernard Fisher, and in 1967, he took over as chairman of what was soon to be called the National Surgical Adjuvant Breast and Bowel Project, or the NSABP. And basically, this was coming at a time in the 60s when there were some successes in treating certain kinds of blood-borne tumors with chemotherapy. And so basically the intention was to study chemotherapy in the setting of breast cancer and bowel cancer. But some of the interesting studies that they did first were in dealing with just questioning how we do surgery. And Bernard Fisher, he basically challenged the whole local spread of disease like a crab, and said that because operable breast cancer is a systemic disease involving a complex spectrum of host tumor interrelations, local regional therapy is unlikely to affect survival. And I'm not sure that's completely true. I think it does matter, removing the tumor in its entirety, but it's not the whole picture. And this article in The Atlantic kind of summarized it, that before 1971, if you had breast cancer, chances are you'd have your breast cut off. Surgeons had been taught one thing: radical surgery saves lives. It was Bernard Fisher who changed their minds, getting reluctant breast surgeons to enter their cancer patients into clinical trials that tested less aggressive surgery against the Halsted radical mastectomy. And what they did is they first randomized patients to two groups, one where they did this radical operation and the other where they did a simple mastectomy, just removing the breast, as we often do nowadays. And they saw no difference in survival. Then they did another study where they randomized patients into three groups. One where they just removed the tumor, so what we often call a lumpectomy or a partial lumpectomy. The second group where they removed the tumor and they irradiated the breast. And then the third group where they did a mastectomy. And once again, no difference in survival. Okay, there is a difference in local recurrence between doing the lumpectomy with and without radiation, and that's why we do additional radiation. But the important thing is that we, at this point, by developing clinical trials or these studies with randomization, we were able to test surgery and challenge surgeons in terms of what the most optimal way to address breast cancer was at that day. And this was a day where we didn't have a lot of other options in terms of drugs. Nowadays, basically, we've come a long way in terms of what we know about breast cancer. And this is just a picture of a gene expression profile, which kind of looks at more or less, they sometimes call it a heat map. It can look at hundreds of genes at a time, and it can look at what's overexpressed above baseline and what's underexpressed. And then you can kind of fit people into certain groups versus the others. And by doing this, we can now categorize breast cancer in a couple groups. We now can use these profiles to subdivide patients into groups that correlate more or less with certain types of proteins that are expressed on the tumors. The pathologists, they actually, all they do after they examine the tumor under the microscope is they can do special stains for the tumors and see if they can express these particular proteins. And I mentioned the hormone receptors, estrogen receptors, progesterone receptors, as well as another protein that I'll talk about called HER2, which is more or less a oncogene in its own way. Based on the receptors, we can often classify patients. And one group is very difficult to treat, and we still have to study a lot. And it's this one that has what's called a basal-like profile, but it's the one that is triple negative, which means that it does not contain a receptor for the estrogen or progesterone or that HER2. So we don't have a known target yet, but we're still learning about ways to target it. So an example of how we use antibodies in treatment is if you came across a woman with breast cancer, even before they had surgery, they would have what's called a core biopsy, or just a little piece of tissue taken from their tumor. And that little piece of tissue can be sent for these hormone receptors as well as the HER2 new receptor. And if they have the HER2 new receptor that's positive, then what we do know is they're in a subgroup of patients which is typically under 20% of all breast cancers. It's basically a 1/5 of breast cancers that what used to do poorly, but now that we have a targeted therapy, actually does quite well with treatment for breast cancer. And it's actually a treatment where they give via IV this antibody that blocks that receptor. And right here it's called Herceptin, or the other word for it is trastuzumab, which is a very confusing word. But basically the long and the short of it is now we've developed certain medications that really, this has now been out since the 2000s, but we can give this medication in addition to chemotherapy to be a little bit more refined in treating these cancers. And this is a kind of a chart on the right that shows that the group, which is the top line, basically has about half as many recurrences as the group that did not get the antibody, trastuzumab or Herceptin. So Herceptin in and of itself reduced risk of getting that tumor coming back, which is a good thing. Another thing that they've done is what's called a gene expression signature, and this is looking at not just one gene, but anywhere from 21 to 70 genes at once. And these are marketed in different ways. There's one called Oncotype DX, which is a 21 gene recurrence score. And they basically, it's the group of genes on the right. They look at all these genes at once, and based on whether they're upregulated or downregulated, they can categorize you if you have a low risk, an intermediate risk, or a high risk of having a recurrence. And then you can use that information to help you decide if you need to give chemotherapy or not. Because if you're low risk of recurrence, it may not be worth putting yourself through something that's toxic. But if you're a higher risk of recurrence, you might say, well, you know what, it might be worth it to me. So using these genes, we can actually, this is how we're embarking in a way of personalized medicine. This is what your tumor is kind of fitting in. And another example is this one called MammaPrint, which looks at 70 genes at once. And it doesn't look at likelihood of recurrence, it looks at overall survival. So it can put you into a group that is more or less likely to die. And you can use that information to help you decide how aggressive or not aggressive you want with certain therapies. going to kind of change this up and talk about a different kind of tumor. And this is called GI stromal tumor, or GIST. And it's a tumor that really is of the class of sarcoma. And it's basically a tumor that's derived from a bowel, whether it be stomach or small bowel or even colon, okay? But it's derived from the wall of the bowel, okay? And not so much the lining. And these are just some pictures just showing that under the microscope they kind of look like spindle cells, which is how a lot of sarcomas look like, and how they can create little masses, which this is a upper endoscopy on the left, which is looking up. And on the right, this is an intraoperative picture. I was doing a laparoscopic GIST resection, and that's just a picture after I put a stitch into the GIST and pulled it out right before putting a stapler across it. And I think I have a little bit of a video. This is another picture just to show some of the stuff we can do as surgeons of a patient who had a GIST right by the junction of their esophagus and their stomach. And this is a special device called a laparoscopic stapler that we can use to actually simultaneously cut bowel, put staples on bowel, as well as cut it. So you can kind of seal bowel and at the same time divide it all at once. And so you're seeing that the staples kind of fire, and then it pulls back and cuts, and it's divided a little bit. So that's one of the methods that we can do to minimally invasively remove these tumors. And one of the things when I say that the decision-making is guided by what we know about biology, this kind of tumor does not spread to lymph nodes. So all you have to do to remove it is you can just come up close to it and remove it. So you can have a very kind of controlled resection on it. If this was a gastric cancer, the recommendation for surgery might be quite different. But basically, the cool thing about GIST is not that you can remove it by interesting ways, but really it has come from what we've learned about its biology. And basically, GISTs are a class of tumors that have been one of the first that has been well studied in terms of its ability to respond to targeted therapies. And GISTs express a receptor, and they sometimes call it c-KIT, but it's basically a tyrosine kinase, and it's on the surface of the tumor. And basically these tyrosine kinases, they get stimulated, and they can act to kind of promote all the different features of cancer that we talked about, whether it be promoting blood vessel formation or evading cell death or growth or differentiation and movement or migration. So effectively, this is one target out of possibly many that could be looked at. But what they found out in GIST, particularly in patients who had metastatic disease, is this drug that was kind of released by the FDA around 2001, Imatinib, was found to be very selective and targeted for these tumors. And this Time magazine, is this the silver bullet? That's a good question. What they did find is a lot of patients actually do respond to this tumor, which is great. But there are also a lot of patients who, after many months or years on it, can sometimes develop resistance to it. So basically, more of these similar types of drugs, the similar class of drugs, these receptor blockers, have been developed in terms of to use as second-line agents or agents that you would give if a patient showed resistance. And we now do, if we are going to choose for a patient who has one of these tumors, a GIST tumor, you can even determine the specific mutation and they can determine whether your mutation is what's called exon 9 or exon 11, just a specific point of the mutation. And depending on where the mutation is, they may be more or less responsive to the medication. And you might use 400 milligrams for one mutation and 800 milligrams for the other mutation. So things have become very, very specific. This is just an example of a pathway. It's called the MAPK pathway, and there are lots of pathways. And when I tell you, cells are complicated, they really are. And there's no reason to kind of memorize this or just come away with an understanding of that. For one target may hit one protein, and you might have another target hoping to hit another protein, and you might actually have to take cocktails of these drugs to be able to evade a resistance. And we're still learning about that in terms of how to deal with this. But certain things are very particular to knowing if the patient has a particular mutation in their tumor or not. And one of the things that they've found in this group of patients with melanoma is they basically looked at this one particular mutation called the BRAF, which was in that same pathway that we just looked at. And by using an inhibitor of that pathway, they're able to show that this patient, this is a PET scan that shows tumor that has metastasized, unfortunately, to a lot of different places in their abdomen and chest, that being on this tumor itself slowed everything down, and that their liver tumor shrunk, and their lung tumor shrunk, these little metastases disappeared more or less, and their bone involvement disappeared. Now, some of these things that we're seeing are unfortunately short-lived in many, but we're still learning. And unfortunately, when we study these in patients who have metastases, sometimes they have so many different mutations going on that just hitting one target is not enough. So the limitations of some of these are that you can develop resistance to some of these drugs, and it may be very similar to how we learn to treat HIV, that you don't just have one antiviral, you have three, that you might have to trial cocktails or combinations of medications in order to limit that. That more than one pathway can be disturbed, so you can find another way around that. And it's similar to trying to control the traffic pattern in a big city just by hitting one corner of just having a cop at one traffic light. You're not probably going to do a lot of headway. You may have to divide and conquer, or be more thoughtful about things. And then this concept that's come up in more recent years is intratumor heterogeneity, and that's a very complicated word, but it means that in one tumor you may have a lot of different mutations going on, and that makes it a lot more complicated, that you may not be dealing with just one thing, but the tumor itself, or its metastases that have spread from the original tumor may be quite different from the original tumor. Another target that people are looking at are what are called anti-angiogenesis therapies, and the whole thought is that tumors, I mentioned at the beginning, they learn to recruit a blood supply, but their blood supply is not as effective. It's leaky. It has it's more acidic and less oxygen in it, and it creates kind of abnormal environments within tumors, and those abnormal environments actually make radiation therapy less effective because there's less oxygen for the radiation therapy to act with, and they may actually impair the distribution of chemotherapy. And so by adding in a medication to help normalize the blood vessels in the tumor, you may be able to more effectively deliver medications to those regions. And then another area that's been really hot, especially in melanoma, is this concept called immunotherapy. And that's basically trying to, I mentioned at the beginning that tumors can evade the immune system in some ways. And basically what these special antibodies are allowing the tumor to do is get identified again by your own immune system. So your immune system can then act against the tumor like it hopefully should do for you. There are also certain specific vaccines that have been studied, and right now pancreas cancer, there are quite a few vaccine trials that we are still awaiting to hear the results on. But there's a lot of interest in kind of looking at playing up the immune system in terms of cancer therapy. So in going back to our original question, what is cancer? And I'll once again leave you with the answer that the answer is complicated. It is a disorder of a cell or tissue that is not just one thing. It could be multiple mutations. It could be multiple processes that are going on. It's not just one gene causing it. It's not just the environment. It's not just your own genetics. It's a lot of things happening, but it creates an abnormal process. It's still a challenge for us to learn how to effectively treat. Although we have come through some strides in terms of being able to treat early cancers as well as prevent cancers, and we're still working on that as well. And then, can we cure cancer? And it's the same answer. It's complicated. But going again to this diagram that I kind of mentioned was proposed initially in 2001 and then has been updated. These are actually all various types of drugs or targets that are now either being studied still in animal models or in the clinic. The EGFR inhibitors are basically that same tyrosine kinase pathway, and that's been studied very well. And we're still learning more about that. This kind of immune medication has now been FDA approved in melanoma, and so and that really has just been over the last 2 or 3 years. And then these medications are now being studied in breast cancer. So there's a lot of new changes and things that, we still have a lot to learn, of course. So I'll be happy to entertain any questions. The 21 gene recurrence score is currently now in what we call the NCCN guidelines, which is the National Comprehensive Cancer Network. They actually have expert consensus guidelines for pretty much almost every cancer type that's been kind of on the recommended course of action depending on the stage of cancer as well as the level of evidence. So something that is high evidence versus low evidence would it's more likely to be on the recommendations if it's a higher level of evidence, such as a randomized trial. With regard to insurance companies, it still depends, but most of them follow Medicare or Medi-Cal, Medicaid, and with regard to the Oncotype DX, for the most part, it's been covered, but it's specific uses are kind of outlined in those guidelines. So it's only a certain kind of group of patients who typically get it, not necessarily everybody. Mm-hmm. Exactly. But there's certain other types of, whether it be newer medications or orphan medications or even PET scans, these fancy other types of imaging studies that we have that are not standard and will not be covered, unless there is a proper indication for it. So while a PET scan may be covered in the setting of lung cancer or esophageal cancer, it would not be covered in the setting of pancreas cancer, for example, and that's just because of its value that's given from the results. Okay, that's a good question. Or is there any blood work or tumor markers or something for the normal population? There is no blood work that is of value for screening for cancer, and here we're using the word cancer, encompassing all of the cancers. There's nothing of value in that sense. The use of tumor markers is limited to certain kinds of cancers. There are certain tumor markers, for example, that are very specific to ovarian cancer, or perhaps pancreas cancer. And it's allowed for people who have a known diagnosis. For example, if you have colon cancer, there's a tumor marker called CEA that after you've had your colon resection, when you're now in your surveillance phase, or you're basically monitoring yourself for recurrence, you will get covered your ability to get a tumor marker called CEA. But before you have a diagnosis of colon cancer, it actually is very imprecise and not of good yield in that. There are things called false positives that certain kinds of these tumor markers can have, that you can have an elevated response and not have a cancer, and then also have situations where you have a cancer and not have an elevated tumor marker. So they're highly unreliable. For breast cancer, there is no recommended tumor marker. Yes, the question is there any research of how to prevent a patient from going into relapse or having the tumor come back after they've gone into remission? And a lot of that is what we do with breast cancer. Because with the early breast cancers, there are, for example, in the case where I was saying that sometimes you can have a small tumor that's hormone positive. What you can do is if you put yourself on a medication to block that hormone, one of the medications is called tamoxifen, and then there are a whole class of drugs that prevent estrogen from forming in your body, and that actually decreases your risk. What it can do is it can decrease your risk of getting the same cancer back in the same side of your breast, but it can actually decrease your getting a new cancer in your other breast by 50%. Okay, and that it mainly acts on the hormonally positive breast cancers because it is a hormone blocker, but that in and of itself is a way to prevent in that breast as well as prevent a recurrence. So prevent a new cancer as well as prevent a recurrence all at the same time, if that makes sense. My research interests, I'm actually looking more at population-based within the region of Southern Illinois, and of outcomes from both pancreas and esophageal cancers. And that's partly because those are cancers that have been linked to what are called volume outcomes relationships. That there's a relationship between the hospital you go to and the likelihood of having a good or bad outcome from those kinds of particular cancers. But I want to also evaluate if there's a downside to distance, if people have to drive a long distance, if that actually influences outcomes for patients who have these cancers, that they don't get properly staged. The other thing that I've been looking at, and I did my PhD actually looking at the role of a bacteria as a cancer therapeutic. And that is something that's probably not ready for prime time, but looking at bacteria, and we're actually now using viruses to deliver genes into tumors. But what I was looking at is using bacteria that, like low oxygen environments to deliver certain proteins into tumors. And the nice thing about bacteria is they are like little machines already, that they have all the machinery to make proteins. And so if you set it up a certain way, that you can have a bacteria actually make a protein for you and have it targeted to a location that you want it to go to, depending on certain properties. So that's something that I was doing some research in. And then I had also done some research in looking at the whole process of metastasis or spread of cancer, and looking at specifically, are there certain types of early metastasis where it's limited that you can actually remove with surgery. And that's still a very still a controversial subject on the role of surgery for metastatic disease.